My name is Anahita Fatih Kazaruni. In this video, I'm going to explain our paper recently published in the Journal of Magnetic Resonance Imaging. This work was performed under supervision of Dr. Saligheh at Tehran University of Medical Sciences with the grant provided by this university. I'm going to show you that ADC-derived spatial features can accurately classify adnexal lesions. 10% of women have surgery for a suspected ovarian mass during their lifetime. Accuracy of conventional MRI for adnexal masses could be less than 70% for inexperienced radiologists. False positives happen if benign masses appear with visible enhancement on contrast-enhanced D1-weighted images. This can result in overoperation for benign masses. False negatives could happen if malignant masses appear with unenhanced intensity on contrast-enhanced D1-weighted images, and this could lead to underoperation, which imposes a risk for malignant masses. So there is a need to use advanced MRI methods to complement the diagnosis provided by conventional MRI. Diffusion-weighted images are used to qualitatively rule out malignancy, meaning that they are used to predict benignity. The role of quantitative DWI or ADC map for differentiation of adnexal masses is a matter of debate. It is because there is a large overlap of ADC values between benign and malignant lesions. Intratumoral heterogeneity on MRI shows spatial variations in blood flow and cell density. So in this regard, ADC map could be very helpful, but mean ADC averages out the heterogeneity information, and this is the reason why we cannot separate benign from malignant and adnexal lesions based on their ADC values. So instead of calculating mean ADC, we have to find a tool that preserves and quantifies spatial heterogeneity of adnexal masses. Our hypothesis is that the environment of adnexal masses can be represented by a specific category of texture features. So here we try to quantify heterogeneity in ADC maps using whole lesion spatial or textural features. We have applied MRI acquisition at 3 Tesla on 70 patients who were histopathologically confirmed with 38 benign masses, 3 borderline, and 29 malignant tumors. DWI was applied using 3 p-values of 50, 400, and 1000, and ADC maps were generated using monoexponential fitting on the MRI concept. Our analysis and quantification composed of 4 main steps. At first, whole lesions were delineated by an experienced radiologist. Then spatial or textural features were extracted. These features included first-order histogram, GLCM, RLM, and Gabor texture features. Then AIC and BIC methods were used for feature selection. These 2 methods were implemented in forward selection, backward elimination, and stepwise selection strategies, and in total it generated 6 feature selection methods. Finally, we applied classification using linear discriminant analysis and based on leave-one-out cross-validation. So here we had 10 first-order histogram features, 23 GLCM, 44 RLM, and 25 Gabor texture features. Feature selection was performed using 2 strategies. In the first strategy, feature selection was applied on each of the textural categories separately and individually, meaning that on the features of RLM category, feature selection was performed separately from Gabor category, and so on. This strategy was adopted to show that our hypothesis about existence of a specific kind of textural category that can best represent the ecological environment of adnexal masses is true. And in the second strategy, we used the conventionally applied method where all features are accumulated in a feature space and feature selection is applied on all the features. Level 1 of cross-validation was performed in both feature selection and classification steps. So we performed feature selection and classification in two schemes. Scheme 1 was when including all benign masses. Scheme 2 was when we excluded highly specific benign masses composed of endometrioma, hemorrhagic cysts, and teratoma. This scheme was planned to show that a specific textural category can perform accurately even when we exclude highly specific benign lesions. The selected features from the previous step were used for differentiation of benign from borderline from malignant lesions and also for differentiation of borderline from malignant lesions. And comparison was made with qualitative assessment of two experienced radiologists. As you can see here, we have provided population histograms for 38 benign and 29 malignant patients. Based on the shape of histograms, it is difficult to discriminate benign from malignant populations. So there is a need for higher order statistical features or higher order statistics for differentiation of benign from malignant adnexal. When we included all benign masses, and when we had 38 benign versus 29 malignant tumors, the RLM textural category could provide a high diagnostic performance of 97%. And when Gabor was added to RLM, it could reach 100% of accuracy. In the meantime, our radiologists could at best reach 80% of diagnostic performance. We use the same subsets to differentiate between benign, borderline, and malignant lesions, and RLM could provide high diagnostic performance of 88%. And when we added Gabor to RLM, about 100% of diagnostic performance could be achieved. And for differentiation of borderline from malignant, RLM and RLM plus Gabor texture features could provide 100% of accuracy. When we excluded highly specific benign lesions and when we had 14 benign versus 29 malignant tumors, again, RLM textural category could provide 100% of diagnostic performance. In the meantime, our radiologists could at best reach 67% of accuracy. Same subsets were applied for differentiation of benign from borderline and malignant lesions, and also for differentiation of borderline from malignant lesions. And as you can see, RLM still can provide 100% of diagnostic. Here you can see an example of a patient who was histopathologically confirmed with mucinous cyst adenoma. The radiologist suggested malignant lesion based on conventional MRI images, but our methodology could accurately classify this lesion in the benign group. In conclusion, whole lesion spatial quantification could preserve the heterogeneity information. It is as opposed to region of interest-based analysis and mean ADC, where the spatial information is averaged out. Our proposed method can differentiate between benign and malignant, borderline from malignant from benign lesions based on their cellular distribution. And we show that there is a specific textural category that can best describe the properties of a certain tumor type. Here, for adnexal masses, RLM performed the best. RLM textural category has high accuracy with and without including highly specific benign masses. And this method can be added to conventional MRI diagnosis to aid the radiologists. Thank you for your attention.